All right, thank you, Jen. My name is Dr. Jessica Collins. I am a foot and ankle surgeon, a podiatrist at Mercer-Bucks Orthopedics, and my lecture today, as Jen noted, is diagnosis and treatment of ankle sprains. So just to go over an outline of what I'll talk about, I'll give you guys a little bit of background information. I'll talk about some anatomy, classification, some of the history and physical exam findings with ankle sprains, imaging studies, acute versus chronic injuries, and then conservative and surgical treatments. And at the end, I'll just summarize it all up for you. So background information, ankle sprains are really, really common injuries. They're one of the most common injuries I see within my practice and that we see in our practice overall. One study quoted that ankle injuries occur in the US at an incidence of 1 in 10,000 persons a day. So 1 in every 10,000 people sustain an ankle injury daily. Most common between the ages of 10 to 19 years during sporting activities. That, is something that's really variable within the literature, but of course it is really common in more active populations and especially in younger people. It's more common in males between the ages of 15 to 24, and then females over the age of 30, pardon me. Sports-wise, again, there's a lot of variability if you look at the literature regarding which sports are associated with ankle injuries, but in one study I found basketball was the most common sport associated with ankle injuries and ankle sprains, followed by football, soccer, and running. Acute sprains have a high recurrence rate. So you might have heard this before, if you ever sprained your ankle or know somebody that sprained their ankle, they sprain it again, they sprain it again, they sprain it again. And that's because of the association with the development of something called chronic ankle instability. So a little more background here. An ankle sprain technically is defined as an injury most prevalently to the lateral ligaments of the ankle. The lateral aspect of the ankle is the outside of the ankle, as demonstrated in this picture right here. This is the lateral aspect. And typically this is via an inversion mechanism. And this is an excellent example of inversion. It's when the foot twists inward on the ankle itself. And that causes tension on the ligament structures that hold our ankle on the outside and thus an injury. A medial ankle sprain is not common, or not as common, I should say, and it typically results in the opposite of inversion, an eversion mechanism. And eversion is when the foot is rotated inward, or the ankle inward here, as you see. Rotation mechanisms, so rotating in versus out, can cause an injury to another ligament complex within our ankle called the syndesmosis. So anatomy, the lateral ligaments, the outside of the ankle demonstrated here, is composed of 3 ligaments: the anterior talofibular ligament, the ATFL, which is the most commonly injured ligament, the calcaneofibular ligament, or CFL, and the posterior talofibular ligament, pardon me, the PTFL. The PTFL, for whatever reason, is absent on this picture, but here you can see this is the ATFL, this is the CFL here. The medial ankle, or the inside of the ankle, is composed of our deltoid ligaments. Again, that's not, and it's not as common to have a medial ankle injury, so the real focus of this lecture is on lateral ankle injuries, but a lot of the concepts apply to both the inside and outside of the ankle. Syndesmotic ligaments, they're higher up on the ankle, so you might have heard before the phrase a high ankle sprain. That can be when the ligaments that are higher on the ankle, when those are injured. The syndesmotic ligaments are very important. They hold the fibular bone, which is the outside bone of the ankle, and the tibia together. And they're composed of the anterior tibiofibular ligament, the posterior tibiofibular ligament, and an interosseous ligament or membrane. So classification, ankle sprains are typically classified based on the severity. A grade 1 injury is a mild injury. It's considered a mild stretching or small tears within a ligament structure. A grade 2 injury is a partial thickness tear, or a larger tear than a grade 1. One of the differences as you increase severity, you also may notice here it says joint instability. So in a grade 1 or in a mild injury, you don't typically see that the joint is unstable, and that's because the ligament structures are still held in place. In a grade 2, you have some partial tearing, so there's some mild instability. And then in a grade 3, which is the more severe, you have complete tearing of ligaments, and so therefore you have instability. Ligament structures are structures that hold our joints in place. They keep bones together. So if you lose the integrity of a ligament, if a ligament tears, then the joint itself can become unstable. So on physical exam, this picture here, you can see some bruising. I always find in the lower extremity, bruising can settle in funny places. So what I mean by that is you might injure your ankle, you might roll your ankle towards the outside, towards the inside, and then notice your toes are bruised. And that's just because of the way bruising can settle. Sometimes patients come in and they have extensive bruising and they're shocked to find out they don't have a fracture because you can see severe bruising with a sprain. And sometimes, on the other hand, patients will come in and they won't have a lot of bruising. So that is somewhat patient specific. Swelling, like I said, it's swelling and bruising that are the most common things that you find. Also having some difficulty putting weight down on the foot. That's a big sign too that there is an injury to either the bones or the ligaments. There is, within our field, there is a 15-step or a 15-point evaluation that we perform on foot and ankle patients, especially after an ankle injury, that allows us to assess all of the bones, the tendons, and the ligament structures. So palpation, which is feeling of bony and soft tissue structures from toes to knees, should be performed in your physical exam. The reason that you have to go all the way up to the knee and all the way to the tips of the toes is because there are some really common injuries that are associated with ankle sprains. One major associated injury is something called a Mason-Oak fracture or a high fibular fracture, which is at the fibula, the outside bone of the ankle, and where it articulates with our knee at the upper part of the leg. Another commonly associated injury is a fracture to one of the metatarsal bones in the foot. It's also important to evaluate the medial and lateral ligaments, obviously, when you're evaluating for an ankle sprain or even a bony injury, and that's through a couple different tests that we do. One test is known as the anterior draw test. Ultimately, what the physician does is they hold your leg and they pull the ankle forward. And in doing that, if you can pull the ankle forward more so on the injured side versus the uninjured side, then that's a very good sign that there is an injury to the ligament structure, and most commonly the ATFL, but it can be the CFL as well. The Taylor tilt test is a test that we do where you hold the heel and you invert the heel or you roll it outward. And in doing that, you're able to assess the CFL, but that is a test that we have to do with X-ray. And really, I just wanted to include all of this for completion's sake and just to give you a little bit of background on some of the things that you might experience when you go into the doctor to be evaluated. So to evaluate the syndesmosis, there's a test that we do called the medial to lateral squeeze test or the leg squeeze test. And that's really squeezing the leg from the inside and the outside and pushing. Really, this was a great picture because it does show the area of the syndesmosis, but pushing where that ligament structure is at the front of the ankle and the back of the ankle. If a patient does have pain here, if we're worried about a high ankle sprain, then there are certain x-rays or certain imaging studies that we get called stress imaging studies that can help us evaluate that further. So that leads us on to imaging studies here. So plain non-weight-bearing x-rays with contralateral comparison if needed is typically the first line analysis that we perform. An x-ray itself can give us a lot of information. You can see the bones, you can assess the joint structures, and typically we look at both the foot and the ankle, and sometimes the knee too, as I mentioned, depending on where a patient's pain is and the mechanism of their injury. The word contralateral means the other leg, so it is very helpful to be able to get a comparison study to evaluate the difference in joint integrity and the way that the bones appear, between the two limbs. Special views, I also mentioned on here, the most standard views that you'll see are an AP oblique and lateral. And again, this is all for completion's sake, just so you have a little bit of background and understanding of what you may experience when you come into the office. So a standard view, the doctor will order, the x-ray tech will have you position your foot in 3 different ways, your ankle in 3 different ways, and take pictures of it. And then there's these special views where while you're taking the x-ray, you actually apply pressure to the foot and the ankle. You're able to twist the foot and the ankle, and that opens up the joints and enables you to evaluate the joints a little bit better. So out of Canada, Ottawa ankle rules came about. A big study was performed and gave us some guidelines as to whether or not x-rays are indicated after an ankle injury. I've had a lot of people that come in and, they'll say, I sprained my ankle, why do I need an x-ray? Or, I can tell it's only soft tissue, why do I need an x-ray? And x-rays give us a lot more information, than just the bone. You can see the joints as well. So that's why it's important. And then we always go by these rules here as well. So ankle x-rays are necessary if there is pain near the malleoli. Those are the bones on either the inside or the outside of the ankle. And then one or more of the following. So if you're over the age of 55, if you were unable to put weight down as soon as the injury happened, or if in the emergency room or urgent care or right after the injury, you weren't able to take more than 4 steps without feeling pain in the bone. That is an indication that an x-ray is needed. Foot x-rays are needed when there is pain towards the middle of the foot or tenderness on specific bones within the foot, because that is associated with different injuries. On x-ray, as I've mentioned a couple times here, evaluation of bony structures and articular changes are visible. And when the joint or the articulation surface changes on an x-ray, that's an indication that a ligament or the support structure has been injured. Because if the support structure is injured, then you're going to see a shift on the x-ray. So MRIs. MRIs are so valuable, and they're something that we use very often within medicine. However, they're not what we consider a first line analysis after an ankle injury. I very often get asked, I sprained my ankle, I need an MRI, I need an MRI, but they're not required with acute injuries. And that's because the findings do not typically change the treatment course. And insurance companies oftentimes aren't going to pay for an MRI because, again, it's unlikely to change the treatment course. The other reason you would get an MRI, or a reason I should say you would get an MRI, would be if you were worried about a syndesmotic injury or if you needed to plan for surgery. MRIs are essential with planning for surgery, or if you were worried about a pretty severe ligament rupture that would require surgery. You are able to see all the bones and the soft tissue, which makes MRIs a very valuable study. So an acute versus a chronic injury, sometimes you'll look up information on ankle sprains or ankle injuries, and you'll find a lot of different information regarding when you should feel better. I find, after an ankle sprain, patients are typically uncomfortable at first for a few days to a few weeks and progressively feel better, but there can be some naggy pain that lingers, for several months. Ligaments of the foot and ankle are quoted to heal from 6 weeks to 3 months following an injury. That doesn't mean that you're immobilized or unable to, return to work or activities during that time, but studies and research have just shown us that up to the 3-month period, the ligaments are still healing. Acute ankle sprains have a high recurrence rate. I did mention that due to the development of the chronic ankle instability, chronic meaning prolonged and the ankle being unstable. A lot of literature will quote this very high, the recurrence rate very high at 47%, and I've even seen higher than that, but some studies have shown us it's a little on the lower side from 3.5 up to 47%. But either way, it's very common that after you do injure your ankle, you end up injuring it again. History of a lateral ankle sprain is one of the strongest risk factors for future lateral ankle ligament sprains. And a substantial proportion occur in athletes just because of the rigorous lifestyle and the sporting activity itself. So chronic ankle instability is defined as laxity or loosening of the ligaments with joint instability. If the support structure is loosened, if the support structure isn't there, the joint's going to be unstable, and ultimately that interferes with activities. Up to 70% of individuals who sustain an acute lateral ankle sprain may develop chronic ankle instability over a short time. A lot of times we hear the word chronic and we think long-term, because it is, by definition, it is a long-term process, but in a short period you can develop instability that leads to the chronic issue. One study found an incidence of 40% recurrence 1 year after a first-time ankle sprain. So again, these are very high numbers, and the point is just to reiterate how often they recur. It's higher in those that participate in certain sports. I did mention at the beginning, with certain sporting activities, you're more likely to sprain, and that's just because of what you do in the sport. And basketball is a big one, but running, anywhere where you're running, jumping, or cutting from side to side, you have a higher incidence of developing chronic ankle instability and recurrent ankle sprains. So treatment, there's functional treatment and there's non-functional treatment as well. So functional treatment means treatment where you're functioning, you're mobile, you're moving, versus immobilization where you're not moving. Many studies have shown us it is important to mobilize as soon as possible following an ankle sprain. I say that a little bit lightly because though it is important to mobilize shortly after an ankle sprain, it's really important to accommodate and treat the sprain. And if you're in pain, you certainly shouldn't feel, oh, I have to hurry up and get back and start running, or else I have this higher incidence of getting another ankle sprain and things like that. It's important that you take care of the pain, you take care of the swelling, and once you get that under control, getting mobile is very important. Functional treatment, application of a support vise for stability with early active immobilization, or mobilization, pardon me. Greater than 10 days of aggressive immobilization has been found to be detrimental. A lot of research has shown us this, that the longer you go without using it, the longer your recovery is. It can prolong and it can worsen symptoms. So when should you seek help after an ankle sprain? Screening is the very first step. Seeking help of a medical professional as soon as possible is very important. I don't just say that because I am a medical professional. It's important because it can accelerate the healing process and thus prevent injuries in the future and help prevent injuries in the future. If you have an ankle injury, I don't think it's wrong to be assessed, even if you think you just tweaked it, even if you think it's a mild sprain, because there are so many commonly associated injuries with sprains and ankle injuries. It's always worth getting checked out. It's better to be safe than sorry. That's the saying, right? So if you do injure your ankle, if you do roll it, whether it's severely painful or not, it's definitely worth getting checked out. The signs that you might need treatment: difficulty putting weight, as I mentioned, if you're limping, swelling, if you have difficulty performing your daily activities. It's one thing if you have a bruise, right? You have a little bit of soreness, it gets better as the days go on. But if you're limping around, if you can't get into your shoes, if you find that, you can't go on walks anymore and just live your daily life, definitely should get checked out. Initial treatment measures do involve reducing pain and swelling. Like I mentioned, so there is functional early mobilization, which is essential, but initially it's very important to treat the pain and the swelling. And ultimately, by treating the pain and the swelling, you improve the way that you're walking and you improve the mechanics of walking, and thus you're able to incorporate functional activities as well. The therapy that we're often recommending initially is RICE therapy. That's rest, ice, compress, and elevate. I put here possible immobilization because with a severe sprain, or depending on how much pain somebody is in, sometimes we do completely immobilize somebody, but again, it's just for a short time. So if you were to be immobilized, a boot versus a brace, and then crutches, because there's different levels of immobilization. One may say if you're locked up in a brace, you're immobile, but there's still a certain amount of motion that happens, versus if you're in a boot, you're locked up and there's still mild motion, you have bending at the knee, you're putting pressure on it. And then of course, complete immobilization is when you're in a cast or a boot, but you can't put pressure on it. So with a mild to moderate sprain, this should be treated with short-term bracing. Many studies have shown us that bracing is more effective than compression devices alone. So what that means is an actual brace. In this picture, you can see, I think you can see pretty well, there's some laces to it. This is a pretty good, sturdy, bulky brace. This is an example of the brace that we often give in the office. Typically, they have straps on the sides, they lace up. And then in having the straps on the side, you can really pull and stabilize the ankle. Some people I've seen will come in and they have just an ACE bandage on, or there's something called an air cast, which is a brace that just goes on the sides of the ankle. That versus even a compression sock or a compression sleeve. A lot of studies have shown us that they aren't as effective as a more bulky brace like the one here and like the one we usually give in the office. With a moderate to severe sprain, boot immobilization, this is a picture of a walking boot, is often necessary, and sometimes immobilization with crutches. The amount of time that you're in a brace and a boot is variable. I always tend to treat most injuries in 2 to 4 week periods, because ultimately you're really getting used to something over the first week. Swelling's calming down, bruising's calming down, and moving into the second week, you're kind of picking up the pace and starting to get moving in your brace or in your boot, and then we reevaluate you at that point. Almost always, if you are more aggressively immobilized, say you're in a boot, say you're on crutches, there is always a step down process. So with a severe sprain, say you start out on crutches, you eventually start walking in a boot, and then usually you're in a brace before you're back to just normal shoe gear. And the reason that we really tend to do things in a progressive way is just to accommodate the healing process, but also the surrounding structures, and to get you back to function in the most orderly way. So physical therapy is something that is absolutely essential after an ankle sprain. When I say that, I don't mean formal physical therapy always, where you are with a therapist, though that is the best, option. I mean physical therapy even at home on your own, with moving the ankle around, doing stretching, doing different strength and balance exercises. But ultimately, it's absolutely essential to restore function and prevent re-injury. One of the, well, I would say that the most common reason somebody, ends up with a repeat ankle sprain is because they didn't rehabilitate appropriately. They didn't seek physical therapy, they didn't have physical therapy, and they returned to sporting activities or returned to their active lifestyle without that component. Anytime you have an injury to the ankle and you go through a period of time where you're not using it the way that you typically do, other structures that weren't injured get weak. And there becomes this imbalance. So physical therapy is just very important overall after an ankle injury. Physical therapy should be based on the individual. Every individual gets an assessment, and a treatment plan is developed that is based on their specific needs and their functional goals. Initial physical therapy treatment measures typically include hands-on treatments where you're focusing on mobility, loosening tight muscles, reducing pain. There's also a focus on edema control and just overall some light movements, some what we call passive range of motion, and just increasing mobility and reducing pain. The next focus of physical therapy typically is improving the flexibility and the strength of the entire leg, not just the ankle itself, because again, everything gets imbalanced. There's a big focus on stretching and strengthening exercises as you progress through physical therapy. The goal is to strengthen the calf and the muscles that help stabilize the ankle. I've been asked many times after an ankle sprain, and we'll get to this too, but is surgery necessary? And even with a very severe ankle sprain, surgery isn't always indicated, because there's this thought that you can really live with a looser side to the ankle as long as you strengthen the other parts of the ankle and the structures around it. And in saying that, that just, shows how important physical therapy really is while you're recovering from an ankle sprain. So the last phase of physical therapy is primarily focused on balance. Balance is always really affected after an ankle injury, and I think it always, surprises people about how much that really is affected. There's a sensation that we all have called proprioception. This is our balance sense or our position sense, our ability to sense the ground, if you will, and that becomes affected after an ankle sprain. And anybody who's had one, I'm sure, can tell you, after you have, or an injury in general, there's always a hesitation to get back to activities. There's always a hesitation to put weight on it. And that hesitation is something that you can really get over in physical therapy. I find in physical therapy, one of the stronger parts of physical therapy, or the benefits of physical therapy, is they really help get your confidence up. Not only are they working on strength, edema, mobilization, but they help you get your confidence up, and you can see, wow, I can do this, and that helps you from hesitating and helps prevent injuries. So 80 to 85% of all ankle injuries can be treated conservatively with functional rehab. 15 to 20% will continue to have pain and instability following 6 to 8 months of physical rehab and will require surgery. This is a quote out of a very common textbook that's based on literature. 6 to 8 months of physical therapy is not typically required after an ankle sprain, but before truly, knowing do you need surgery or deciding yourself, yes, I want to pursue surgery, I do think it's fair to give yourself a 6 to 8 month period before deciding that. Surgery should always be considered when somebody is not able to return to what we call their functional goals, return to their normal day-to-day activities. If you have pain that is limiting your day-to-day activities, if you have persistent swelling, if you find that you're unable or you don't want to go out and do the things that you would normally want to do, those are all signs that you should definitely see somebody, and ultimately surgery may be indicated. I did mention earlier that an MRI is necessary for surgical planning. That is the case because you can assess the ligaments themselves and you can see which are injured and how severely are they injured. Because if you remember that anatomy picture I showed you, there are several ligament structures around the foot and the ankle. Sure, you might have just injured one of them. Can you live with that? Potentially, or potentially it needs to be fixed. The MRI can just give us a lot of information. The other thing MRIs can show us, and something I haven't mentioned yet, is cartilage can be injured when you have an ankle injury, because ultimately when the foot goes one way, the ankle kind of goes the other way, the joint bumps on itself. It bumps like that when the ankle turns outward and the foot goes inward. In doing that, you can get a little deficit in the cartilage. You can get something that's called an osteochondral lesion. And ultimately, that is something that can require surgery, and an MRI would definitely show that. So surgical measures include ankle arthroscopy for debridement and repair of those osteochondral lesions with minimally invasive ankle ligament stabilization. There are many ways to approach an ankle surgery, if you will. There are many ways to approach repairing ankle ligaments, but overall the goal is always the same. It's to restore the integrity of the joint. It's to restore the integrity of the ligament structures themselves. This can be done through minimally invasive surgical approaches, but it can also require open repair if there are many ligaments that are involved or specific ligaments that are involved. Definitely minimally invasive surgery has the benefit of having you return to activities sooner, but sometimes an open repair is indicated. And we'll talk about that just a little bit. So an arthroscopic versus an open repair, many studies have shown that the strength of a repair, whether it's open or through an ankle scope, is about the same. And this is with focus on the ATFL, the main ligament that's injured, which has its attachment towards the front of the ankle to the foot. That ligament itself needs to be repaired, and even if that ligament and another ligament, the CFL, are injured, you may be able to fix that minimally invasive. Typically after an arthroscopic repair, you are weight bearing right away, followed by a transition to bracing in about 4 to 6 weeks. So you're weight bearing right away in a boot. You transition, like I said, every step if you start out with the highest step, you have to progress down and get through each of the lesser steps. So if you start out in a boot, typically the next step is getting you to a brace. If you start out in a brace, the next step is getting you to a shoe. So typically you're weight bearing in a boot right away, followed by a transition to bracing at 4 to 6 weeks and physical therapy for about 4 to 6 weeks thereafter. Arthroscopically, you can only repair the ATFL, the one ligament, which is the most commonly sprained ligament, but the ligament at the front of the ankle. An open repair may be indicated if more than one ligament structure is damaged, or if there's just severe instability to the ankle, because you can ultimately tie down the ankle support or the ligament supports. When it's open, you can address multiple ligaments versus during an ankle scope, again, you can only address one. With an open repair, typically you're weight bearing after 2 to 4 weeks, depending on the type of repair, how many ligaments needed to be repaired, followed by progressive weight bearing over 2 to 4 weeks, then transitioning to the brace, and then PT. So if you kind of have that scale, you start out on crutches, then you go to the boot, then you go to the brace, then you start physical therapy, getting you back to functional goals. So repair of ligaments is typically performed utilizing anchors. Okay, so ligament structures, they're structures that go from one bone to another bone. So in order to recreate those ligaments that ultimately aren't there anymore, or to reinforce those ligaments, you have to go in the same direction. You have to go from bone to bone. And the way that you do that is with an anchor that goes into the bone. The anchor itself has sutures or stitches that come off of it, and you ultimately are able to sew up or repair the ankle ligament and reinforce the ligament. Sometimes grafting is used. That can be human graft, that can be synthetic graft. It just depends on a lot of different factors and physician preference, but sometimes grafts can be used, and ultimately a graft is used if more than one ligament needs to be fixed and there's a lot of instability. Anchors themselves, they can be metallic or absorbable polymers, which is an absorbable material. That again depends on a lot of different factors, and it's also physician preference. So risk factors for a poor surgical outcome would be obesity, a history of prior surgery, a long duration of symptoms, ligament laxity conditions such as Ehlers-Danlos syndrome. I mentioned obesity, but obesity is definitely a factor when considering an open versus a minimally invasive repair, because one way you can kind of think about it is when you have an open repair, you can address multiple ligaments. And in doing that, you can give a little bit more structure and support, which would be more beneficial in an obese patient. So that's all of what I had to go over. I wanted to give you guys a somewhat brief overview of the anatomy a little bit, and then just kind of go into the basics of ankle sprains. We're really trying to reiterate the point that it is important to seek treatment. It is important to immobilize, but getting you back to function is really important, and how important physical therapy is. So to summarize for you, acute ankle sprains are common. They're amongst the most common musculoskeletal injuries. There's that impressive quote of 1 in 10,000 people have an ankle injury every day. They do have a high recurrence rate as well. There's a strong link between a prior ankle sprain, and an increased risk of future ankle sprains. Most commonly, the lateral ligaments are affected, so the outside of the ankle is typically affected, and it's most commonly due to a twisting or rolling outward, which is inversion. Early diagnosis and treatment is essential because you can, one, get you back quicker, and it can help with preventative measures as well. The longer you wait, the longer it takes to recover. The longer you go without potentially being immobilized when needing it, the more likely you are to develop chronic ankle instability and chronic pain. Diagnosis should include a thorough exam, and that's with palpating or feeling every bone, every joint surface that you can, doing different exams where you're able to stress the ankle, you're able to twist and kind of pull, and that can give you a better idea of how loose the ankle is and which ligaments are injured. Radiographs are important, x-rays, because they can, one, rule out other injuries, but they can also help us assess the joint surfaces and help us determine how severe an ankle sprain is. Ultimately, the treatment almost always is the same. RICE therapy, so the rest, ice, compress, elevate. As soon as you're able to start getting back to activities, getting you back to activity, or activities mean walking, wearing some sort of support based on the amount of support you need, then progressively getting you out with lesser support, and then eventually just back to your normal shoes and your functional goals. I wrote on here MRI in chronic cases and for surgical planning, or if you're concerned about a higher ankle sprain. The reason I mentioned that, and I didn't go into too much detail about that within this lecture, but if you do have a high ankle sprain or a syndesmotic injury, it is more commonly associated with the need for surgery. So that's why an MRI would be important in that case. And yeah, MRIs, again, are not the first line. I always get asked, why don't I get an MRI? It's not just because the insurance won't approve it usually, but it's just because it doesn't change the treatment course. So physical therapy, I know I've said that so many times, but physical therapy, it's not only important for improving the strength of your ankle, improving the stability of your ankle, but it's very important in injury prevention. It's also important just to get you back in a timely manner. Physical therapy should include a program that is designed towards the individual and their goals when they are in therapy, and with a good home program. Because not only is it important to go to therapy and get what you can out of it, but also it's to continue that process at home as well. Initial goals I just said is RICE therapy, that rest, ice, compress, and elevate, and then getting you back sooner than later is very important. Most cases do improve or resolve with appropriate treatment. However, you can develop a chronic case of instability. It is common, and especially with inappropriate or no treatment at all. Surgical intervention can include minimally invasive surgery or an open repair. That depends on MRI findings as well as individual factors and the severity. Because if there is a pretty severe sprain, pretty severe tearing of multiple ligaments, it has to be open, because just by our anatomy and how we do an ankle scope, you can only see the one ligament and repair the one ligament in that way. So that is all I have for you today. I want to thank everybody for taking the time to watch this lecture. I always appreciate when patients are interested in their care and interested in understanding these concepts, and I just commend you for coming and participating, and I really appreciate it. I open the floor to questions now. I have 3 questions here, so I'm going to go over what I can. If you have had multiple ankle sprains, are you more likely to get arthritis later in life in that area? Yes, you are. So I didn't mention some of the long-term consequences of ankle sprains, but the most primary long-term consequence is what's called post-traumatic arthritis. So certainly the more injuries you have, the more potential injury there is to the cartilage of the ankle. And arthritis is ultimately a cartilage disease, and the cartilage wears away sooner or is damaged with a trauma. So the more you have, yes, there is definitely a link with a higher incidence of arthritis later in life. That being said, that correlation, changes when appropriate treatment is given. So you're at a much higher, you have a much higher incidence of developing post-traumatic arthritis if you don't seek treatment. The fact that you've had multiple ankle sprains doesn't necessarily mean that, you're destined to having horrible, arthritis. There are definitely things that can be done now that can prevent that arthritis. So, is there any truth that putting your ankle in a bucket of ice water promotes quicker healing of an ankle sprain? So we like to say ice can be really beneficial for, say, the first 48 to 72 hours after an injury. What ice does, it's an anti-inflammatory. It ultimately closes down blood vessels somewhat, so it decreases the amount of inflammation getting to the area. Ice also numbs the skin, so it can feel good. A bucket of ice, when you initially have an ankle sprain, can definitely promote quicker healing because it can decrease edema. Is it mandatory? No, you don't necessarily have to go into a bucket, but icing, yes, can be very important. It's part of the RICE therapy. And so, yeah, I hope that answered that question. Can a sprained ligament get back to its original pre-injured strength, or will it always be compromised? So there have been research studies, animal studies, human studies that have looked at ligament structures after sprains, and ultimately, yes, it can return to its pre-injury strength, but there's a lot of kind of concepts and thoughts around that. Physical therapy is so essential because it helps strengthen all the structures around that ligament. So even if it is a little looser, or it's not ever going to be the same, it's not anything one would or a person, pardon me, would notice necessarily if it was treated appropriately. How often does a grade 2 or bad grade 2 sprain heal itself without surgery? So regardless of the grade of injury, if it's treated appropriately, I feel that the rate or the percent, that the percent of people that will not need surgery is the same. So I believe on the slide that I showed, it was 80 to 85% of people often go on and don't ever need surgery, and their injury resolves, uneventfully. It's all about the treatment course. It's all about when you seek treatment and the physical therapy and your physical activities when getting back. I did mention that the minimally invasive surgery I talked a decent amount about, but that one of the thoughts is you can only stabilize one ligament. If only one ligament was hurt or partially hurt, it's a more mild sprain, right? If you had multiple ligaments, it's a more severe sprain. But even in a more severe sprain, you don't necessarily always have to do a big open repair. So there is potentially surgery that can be minimal, even if you have a severe sprain. But I hope that answered everybody's questions. And yeah, thank you so much.
Hi, Dr. Collins. Yeah, I think you have answered everyone's questions. I just wanted to thank you for sharing your experience and expertise in the field of ankles with us. I do appreciate it, and it was very informative. I also want to thank everyone for joining us today. And if you do have any additional questions that come up, and you can call us at 855-896-0444, or you can email me directly at programs@mbortho.com. And I will be sure to consult with Dr. Collins and get an answer back to you shortly. Again, thank you for coming in, everyone. Enjoy the rest of your day. Thank you.